Wow, good morning, clinical clerks. I'm recording this just 30 minutes before lunch. I'm moving on to the cardiovascular system from the last few topics being in the gastrointestinal system. My reference, as always, is Tintinalli's Emergency Medicine. I will be doing some ad-libs every now and then, but not all the time. Chronic hypertension is categorized into three classifications: pre-hypertension, stage 1, and stage 2 hypertension. When it comes to the JNC 7 classification of hypertension, which still holds true to this day as far as thresholds are concerned, however, some guidelines have been changed in the more recent updates to JNC. Normal blood pressure is a systolic blood pressure of less than 120 millimeters mercury and less than 80 millimeters mercury. Prehypertension is a systolic blood pressure of 120 to 139 or diastolic of 80 to 89. Stage 1 is 140 to 159 or 90 to 99 in diastolic. And systolic stage 2 BP is greater than or equal to 160 or greater than or equal to 100 diastolic. Hypertensive emergency is an acute elevation of blood pressure at greater than or equal to 180 over 120 millimeters mercury associated with end organ damage, and the targeted end organs include the brain, heart, aorta, kidneys, or eyes. This is distinguished from hypertensive urgency, which is an elevation of blood pressure which doesn't have any end organ damage. Acute hypertensive emergencies are more common in chronic hypertensive patients who fail to adhere to their antihypertensive therapy regimens and those who are unable to access outpatient healthcare. Hypertensive urgency is a term for profound elevations in blood pressure without acute target organ dysfunction. An arbitrary blood pressure of greater than or equal to 180 over 120 millimeters mercury is often cited as an urgency and an indication for rapid pharmacologic intervention, often parenterally, to reduce blood pressure within hours. However, no clinical benefit of such treatment exists, and risks can occur from precipitous drops in blood pressure. Hypertensive urgency is better seen as another form of severe hypertension, where prompt therapy with oral agents is the best path, seeking reduction in blood pressure over days to weeks. Hypertensive emergencies include acute aortic dissection with signs and symptoms of chest pain, back pain, unequal blood pressures in the upper extremities with a greater than 20 millimeters mercury difference. Evidence of acute end organ damage includes abnormal CT angiograms of the chest and abdomen or pelvis or transesophageal echocardiograms of the aorta. In acute pulmonary edema, this may present as shortness of breath with interstitial edema on chest radiograph. In acute myocardial infarction, chest pain, nausea, vomiting, and diaphoresis may occur with changes on EKG or elevated levels of cardiac biomarkers. In acute coronary syndrome, chest pain, nausea, vomiting, and diaphoresis may also occur, but there is no infarction yet, and generally speaking, acute end organ damage is on a clinical diagnosis with changes on EKG or elevated levels of cardiac biomarkers. We're going to tackle myocardial infarction again in the future. In acute renal failure, these patients may have systolic or diastolic abdominal bruit with elevated serum creatinine as a marker for failure of the kidneys to function properly, and proteinuria. Severe preeclampsia, HELP syndrome, and eclampsia, which was partially tackled in the previous topic on hepatic disorders, may present with seizures and proteinuria hemolysis, which can cause higher levels of indirect bilirubin, definitely the unconjugated one. Elevated liver enzyme levels, which is why it could get confused for hepatic diseases, and low platelet counts. In hypertensive retinopathy, blurred vision may be the symptom, and you can see scattered flame or splinter hemorrhages and cotton wool spots, which are nerve fiber layer infarcts in a patient who presents with headache and the blood pressure that is elevated. And you could see hard exudates and sausage-shaped veins. In hypertensive encephalopathy, the patient may have an altered mental status, nausea, vomiting, and headache. They may see papilledema or arteriolar hemorrhage or exudates on fundoscopic examination, cerebral edema with a predilection for the posterior white matter of the brain on MRI may also be visualized. On subarachnoid hemorrhages, headaches and focal neurologic deficits are most commonly implicated, with abnormal CT scans of the brain, red blood cells on lumbar puncture. In intracranial hemorrhages, headache, and new neurologic deficits may be found with an abnormal CT scan of the brain. In acute ischemic stroke, neurologic deficits are often corresponding to the affected side with an abnormal MRI or CT of the brain. In acute perioperative hypertension, you have bleeding that is unresponsive to direct pressure during the middle of surgery, and it can manifest with other hypertensive emergencies. And in sympathetic crisis, acute end organ dysfunction may not be measurable, but complications affecting the brain, heart, or kidneys may occur in the absence of acute treatment. Sympathetic crisis manifests with anxiety, palpitations, tachycardia, and diaphoresis. It is a clinical diagnosis in the setting of sympathomimetic drug use, such as cocaine or amphetamines, or pheochromocytoma, with a 24-hour urine assay for catecholamines and metanephrine or plasma fractionated metanephrines. So, chronic hypertensive patients have biochemical and structural changes in the arterial walls that shift the vascular autoregulatory curve, requiring higher arterial pressures to maintain end organ blood flow, notably in the brain. Eventually, the ability to adapt is past. The resultant mechanical wall stress and endothelial injury lead to increased permeability and excessive perfusion of the cerebral, cardiac, and renal vascular beds results. This can be followed by activation of the coagulation cascade and platelets, and deposition of fibrin results in fibrinoid necrosis of the arterioles. Clinically, this is manifested by hematuria, which is manifestation of the involvement of the renal vasculature, or arterial hemorrhages or exudates on fundoscopic examination. Further contributing to the damage are prostaglandins, free radicals, cytokines, and mitogenic chemoattractant and proliferation factors, which result in endothelial damage, smooth muscle proliferation, and thrombosis. The renin-angiotensin system may also be activated, which leads to vasoconstriction. Pressure natriuresis occurs, leading to volume depletion, prompting additional release of vasoconstrictors from the kidney. These combined effects produce hypoperfusion, ischemia, and dysfunction of end organs. Endothelial dysfunction from such crises can persist for years after the acute event. Blood pressure in both arms is measured quickly and consecutively while the patient is quietly resting. We check the blood pressure several times before starting antihypertensive therapy. Blood pressure differences can result from aortic dissection, coarctation, peripheral vascular disease, and some unilateral neurologic and musculoskeletal abnormalities. So, specific diseases that are associated with elevated blood pressures include subarachnoid hemorrhage, with a threshold value raising risk of greater than or equal to 140 millimeters mercury systolic. Ischemic stroke has two cutoffs at greater than or equal to 140 millimeters mercury or 160 greater than or equal millimeters mercury. For intracerebral hemorrhage, you have the same threshold value raising risk as ischemic stroke. For type B aortic dissection, you have greater than or equal to 140 millimeters mercury for systolic blood pressure and greater than or equal to 90 millimeters mercury diastolic blood pressure. For type A aortic dissection, it is greater than 150 millimeters mercury, acute heart failure greater than 140 millimeters mercury, and for NSTEMI acute coronary syndrome, you have greater than or equal to 140 or 160 millimeters mercury as your threshold value raising risk. Interarm blood pressure differences are also reported in quote-unquote normal individuals. The most important factor in blood pressure difference is increases in age, with the thought that loss of vascular elasticity or asymmetrical atheromatous narrowing of the subclavian or brachial arteries might be causative. Although there are no guidelines or standards for determining the significance of blood pressure measurement disparities, a between-arm difference of greater than 10 to 20 millimeters mercury is suggested as meaningful, and each 10 millimeter mercury difference carries an increasing mortality hazard. When a blood pressure difference is detected, treat the higher blood pressure and make sure that subsequent measurements are made on the same arm. Blood pressure measurements with wrist oscillometric devices give lower readings than arm measurements, so arm measurements are preferred. Use the same device for repeat blood pressure measurements. After careful blood pressure measurement, the next question in a patient with severely elevated blood pressure is whether this constitutes a hypertensive crisis. Although a modest drop of 4 to 12 millimeters mercury in systolic and diastolic blood pressures can be expected in patients presenting with elevated blood pressures, do not discount a diagnosis of hypertensive emergency simply because the patient has no prior history of hypertension. Up to 16% of patients presenting with hypertensive emergency have no known history of hypertension. The key is to seek acute and organ involvement. Rapid diagnosis and treatment of acute aortic dissection are critical because delays increase mortality. Differentiating the relatively uncommon aortic dissection from the more common acute coronary syndromes is important because blood pressure management is different in these two disorders, and anticoagulation can prove catastrophic in a patient with acute aortic dissection. Acute aortic dissection presents with abrupt, sudden onset of pain, usually in the chest, often described as tearing or ripping and radiating to the interscapular region. Less than a quarter of patients with acute aortic dissection have a neurologic deficit or pulse deficits based on blood pressure differentials greater than or equal to 20 millimeters mercury, and only about a third have a diastolic murmur. So that being said, there are only less than a quarter or probably a third of patients who have other symptoms, less than a quarter having a neurologic deficit, and only about a third having a diastolic murmur in the setting of acute aortic dissection. The chest radiographs are abnormal in most, but usually nonspecific, and only 25% of radiographs demonstrate the classic mediastinum, so CT scan of the chest is needed for diagnosis. EKG changes are nonspecific, but less than 10% demonstrate findings that are consistent with a myocardial infarction. D-dimer testing cannot be used in isolation to exclude the diagnosis, but elevated D-dimer and C-reactive protein levels are associated with higher in-hospital mortality. Elevated blood pressure, headache, and focal neurologic deficits are associated with either ischemic or hemorrhagic strokes. Acute ischemic strokes may be diagnosed with MRI, and cerebral hemorrhage is identified on head CT. Hypertensive encephalopathy is a clinical diagnosis after excluding focal ischemia or bleeding. It is characterized by altered mental status, headache, vomiting, seizures, or visual disturbances, and most patients will have papilledema. When MRI findings demonstrate reversible edema that is primarily focused posteriorly on the occipital versus frontal regions, this is referred to as posterior reversible encephalopathy syndrome. Patients with new onset renal failure may have peripheral edema, oliguria, loss of appetite, nausea, and vomiting, orthostatic changes, or confusion. However, some patients have few or no specific symptoms. Elevated serum creatinine confirms the diagnosis, and urinary sediment is also abnormal. Preeclampsia is associated with hypertension, peripheral edema, and proteinuria. These patients may also develop hemolysis, elevated liver enzyme levels, and low platelet counts, such as HELLP syndrome. There are 4 settings in which an excess of catecholamines can result in a hypertensive emergency. An acute catecholaminergic syndrome may occur with abrupt discontinuation of oral or transdermal clonidine. The withdrawal syndrome is potentiated by concomitant beta blocker therapy due to unopposed alpha-mediated vasoconstriction. Pheochromocytoma is rare, and between 5 to 20% of tumors are malignant. Patients may experience life-threatening hypertension. Signs of pheochromocytoma include headache, alternating periods of normal and elevated blood pressure, tachycardia, and flushed skin, punctuated by asymptomatic periods. Sympathomimetic drugs such as cocaine, amphetamines, phencyclidine hydrochloride, and lysergic acid diethylamide can precipitate an hypertensive emergency with tachycardia, diaphoresis, chest pain, and depending on the agent, mental status changes. Patients receiving monoamine oxidase inhibitor therapy who consume tyramine-containing foods may develop a hyperadrenergic state. Autonomic dysfunction due to spinal cord or severe head injury or abnormalities such as spina bifida may also present as a hypertensive emergency with a diagnosis made clinically based on existing injury. Formal recommendations for the evaluation of a patient presenting with asymptomatic but severe hypertension do not exist. Commonly ordered tests include the basic metabolic panel, EKG, chest radiograph, and urinalysis. Treatment for hypertensive emergencies are characterized by diagnosis. Hypertensive emergencies in pregnancy are also managed according to the specific emergency. Acute aortic dissection is the exception in the goal of minimizing end organ damage by initial blood pressure reduction while avoiding hypoperfusion of cerebral, coronary, and renovascular beds because the risk of morbidity and mortality due to inadequate blood pressure and heart rate control outweighs the risk of hypoperfusion syndromes. The therapeutic goal in acute aortic dissection is a systolic blood pressure between 100 to 140 millimeters mercury and the heart rate of less than or equal to 60 beats per minute. The resultant reduction in tachycardia decreases the shearing forces and the aortic wall stress, limiting the progression of the dissection. Pain control with opioids helps to decrease sympathetic tone. The treatment of hypertensive pulmonary edema is tailored to the underlying pathophysiology, which could be due to either transient left ventricular systolic or diastolic dysfunction, acute dyssynchrony, or ischemic mitral regurgitation. Occasionally, the left ventricular ejection fraction may be normal during the acute episode, with only a decrease in systolic function and increased diastolic stiffness and filling pressures, suggesting decreases in systolic function, or rather suggesting decreased myocardial capacity to adapt to changes in loading. For these reasons, there are no clear evidence-based guidelines for the single best treatment of hypertensive pulmonary edema. The mainstay of therapy is vasodilators and intravenous diuretics. Intravenous, sublingual, and topical nitrates reduce blood pressure, decrease myocardial oxygen consumption, and improve coronary blood flow. Diuretics improve symptoms within 6 hours of administration but may not ultimately affect mortality. Be careful using loop diuretics in combination with nesiritide or to a lesser degree nitroglycerin because together these might worsen renal function. In patients with systolic dysfunction, intravenous Nicardipine is an option that increases both stroke volume and coronary blood flow, a potential benefit. When hypertensive pulmonary edema is a result of acute coronary syndrome or atrial fibrillation with rapid ventricular response, beta blockers are an appropriate choice. For patients presenting with severely elevated blood pressure and ischemic changes on EKG, they should be treated with sublingual or intravenous nitrates. Routine intravenous beta blockade has fallen out of favor due to conflicting reports of mortality benefits. It is only recommended for patients presenting with severe hypertension. Oral beta blockade in patients presenting with ST segment elevation MI and non-ST segment elevation MI remains part of early care, but this route may not provide sufficient or rapid enough blood pressure control in a hypertensive emergency. Patients in acute sympathetic crisis due to either cocaine or amphetamines should be initially managed with an IV benzodiazepine such as lorazepam or diazepam to decrease adrenergic stimulation. So let us first review the treatment of hypertensive emergencies by diagnosis. In aortic dissection, goals of therapy are to reduce shear forces by decreasing blood pressure and pulse rate, lower systolic blood pressure to 100 to 120 millimeters mercury, or lower systolic blood pressure to less than 140 millimeters mercury. Pulse rate should be below 60 beats per minute. We measure the blood pressure in both arms and treat the higher blood pressure. Labetalol is given as a continuous IV infusion, or Esmolol is given as an IV bolus and then continuous infusion. These have risks of respiratory distress in COPD and asthma patients, so it is recommended to test the dose of Esmolol first and switch to diltiazem if Esmolol intolerant. Nicardipine is given as an IV continuous infusion after a beta blocker. Always use beta blockers prior to vasodilators. Nitroprusside is also a continuous infusion after a beta blocker, but nitroprusside alone increases wall stress from reflex tachycardia, cyanide and thiocyanate toxicity in patients with reduced renal function or therapy greater than 24 to 48 hours may also occur. In acute hypertensive pulmonary edema, the goal of therapy is to reduce blood pressure by 20 to 30%, diuresis through vasodilation, and symptomatic relief. Nitroglycerin, either sublingually, topically, or as an IV continuous infusion, may be given enalaprilat at IV, Nicardipine as an IV continuous infusion, nitroprusside IV as a continuous infusion, and nisiritide IV, although that one is not available in our setting. Enalaprilat is an ACE inhibitor and can worsen renal function. IV nitrates dilate capacitance vessels at low doses, but higher doses dilate arterioles and lower blood pressure. Avoid hypotension when giving ACE inhibitors. Nicardipine is used with caution. Some patients experience a negative inotropic effect. And for nitroprusside, we have cyanide and thiocyanate toxicity as a warning sign, or rather something to watch out for. In acute myocardial infarction, we reduce ischemia and avoid less than or equal to 25% reduction of MAP. A blood pressure of greater than 180 over 110 millimeters mercury is a relative contraindication for thrombolytics. So nitroglycerin sublingually, topically, or IV continuous infusion may be given, but do not give nitrates in patients who have taken phosphodiesterase inhibitors for erectile dysfunction in less than or equal to 24 hours. Metoprolol or labetalol IV bolus may be given except in congestive heart failure, low output states, or other contraindications to beta blockers. We monitor for hypotension when giving beta blockers. Consider right ventricular infarct and volume depletion. For acute sympathetic crises like cocaine, amphetamine overdose, or Maui toxicity, we reduce excessive sympathetic drive and give symptomatic relief. Labetalol is controversial for this particular disease. If given, we have to administer it with a nitrate. So benzodiazepine IV boluses may be given. They are the first-line agents for acute sympathetic crises, but we observe for respiratory depression due to the effect of benzodiazepine on the central nervous system. Nitroglycerin may be given sublingually, topically, or as an IV continuous infusion. Phentolamine as IV or intramuscular, and nicardipine as an IV continuous infusion. In acute renal failure, we reduce blood pressure by no more than 20% acutely. Do not give nitroprusside as it results in cyanide and thiocyanate toxicity, and we avoid ACE inhibitors acutely. Nitroprusside is given in acute hypertensive pulmonary edema, aortic dissection. Nitroglycerin is given in acute myocardial infarction, acute sympathetic crisis, so far. And nitroprusside is given in aortic dissection, acute hypertensive pulmonary edema. That's basically it for now. Nicardipine is given as an intravenous continuous infusion. For hypertensive encephalopathy, we decrease MAP by 20 to 25% in the first hour of presentation. More aggressive lowering may lead to ischemic infarction, so we avoid that. Autoregulation of cerebral perfusion may be significantly impaired, so avoid rapid blood pressure lowering. Do not give nitroglycerin in hypertensive encephalopathy as it may worsen cerebral autoregulation. So the drugs that can be given in hypertensive encephalopathy include nicardipine intravenously and labetalol intravenously. But we avoid labetalol in sympathetic crisis from drug products. For subarachnoid hemorrhages, we lower systolic blood pressure to lower than 160 millimeters mercury to prevent rebleeding, avoid hypotension to preserve cerebral perfusion, and BP parameters have not yet been defined. Nimodipine is used to decrease mortality. Blood pressure control is not its primary goal, but some decrease in blood pressure may be seen. Nicardipine may be used labetalol as an IV bolus at 10 to 20 milligrams IV or as a continuous infusion. For intracerebral hemorrhage, if systolic blood pressure is greater than 200 or MAP is greater than 150 millimeters mercury, consider aggressive management and IV infusion. If the systolic blood pressure is greater than 180 or the MAP is greater than 130 millimeters mercury and with possible elevation of intracranial pressure, we use infusions or IV boluses while maintaining CPP at greater than 60 millimeters mercury. If systolic blood pressure is greater than 180 and MAP is greater than 130 with no elevated intracranial pressure, the goal MAP is 110 millimeters mercury. Drops in systolic blood pressure that are greater than 150 millimeters mercury are not associated with increased morbidity. Early hemorrhage growth often occurs in the first 6 hours. During this time, aggressive blood pressure control at 120 to 160 millimeters mercury diminishes hematoma growth, morbidity, and mortality. So drugs we can give for intracerebral hemorrhage include labetalol, Nicardipine, and Esmolol. For acute ischemic stroke in RTPA candidates with a blood pressure of less than or equal to 185 over 110 millimeters mercury, if fibrinolytic therapy is planned, treat if the blood pressure remains at greater than 185 over 110 after 3 measurements because our systolic blood pressure goal is between 141 and 150 millimeters mercury. Excess blood pressure lowering may worsen ischemia. Elevated blood pressure spontaneously decreases within 90 minutes after onset of acute stroke symptoms. Labetalol may be given 10 to 20 milligrams intravenous bolus, may be repeated 1 time. Nicardipine is given through an IV continuous infusion of 5 milligrams per hour, titrated up by 2.5 milligrams per hour every 15 to 5 minutes, with a maximum of 15 milligrams per hour. Adjust when the desired blood pressure is reached. Nitroprusside may be used if blood pressure is not controlled with the above agents or diastolic blood pressure is greater than 140 millimeters mercury. For acute ischemic stroke, hypertension excludes RTPA. Treat if 220 over 120 or greater on third of 3 measurements spaced 15 minutes apart. Do not lower systolic blood pressure by 10 to 15% in the first 24 hours. Blood pressure that is lower during the acute ischemic stroke than the premorbid pressure could be considered hypotension. Be careful with blood pressure control efforts in patients taking oral beta blockers or clonidine because antihypertensive syndrome may occur. Labetalol at 10 milligrams IV bolus followed by IV continuous infusion at 2 to 8 milligrams per minute may be given, or Nicardipine 5 milligrams per hour intravenous continuous infusion titrated up to the desired effect by 2.5 milligrams per hour every 5 to 15 minutes with a maximum of 15 milligrams per hour. We monitor for respiratory depression and sedation. If benzodiazepines are not effective in sympathetic crisis, acute sympathetic crisis, we give nitroglycerin or phentolamine. A calcium channel blocker can serve as a third-line agent. Beta blockers can result in unopposed alpha blockade, which then can worsen coronary vasoconstriction and increase blood pressure. If a beta blocker is used, labetalol is the adrenergic blocking agent in conjunction with a vasodilator. In patients with pheochromocytoma and the hypertensive emergency, intravenous phentolamine is recommended. Intramuscular if venous access is impaired. In the preoperative setting, patients who are hypertensive but not in crisis may be managed and prepared for resection with oral phenoxybenzamine, a long-acting adrenergic alpha receptor blocker. Another option before resection is urapidil, although not available in our setting. It's available in Europe. Patients with monoamine oxidase inhibitor toxicity often respond to an intravenous benzodiazepine, but if more therapy is needed, we use phentolamine, nitroglycerin, or nitroprusside. Nitroglycerin is indicated for associated chest pain or cardiac ischemia. We monitor closely after reaching a targeted blood pressure because the hypertensive phase is often followed by a hypotensive phase. In acute renal failure, Nicardipine is suitable for acute hypertension-induced renal failure because it reduces systemic vascular resistance while preserving renal blood flow. Nitroprusside is an alternative, although cyanide toxicity with high or prolonged use dampens enthusiasm in practice. For eclampsia and pre-eclampsia, obstetrical hypertensive emergencies can occur well below the blood pressure threshold for other hypertensive emergencies. For neurologic emergencies such as hypertensive encephalopathy, which is defined as a change in sensorium or seizure from blood pressure elevation, it is a clear indication for rapid blood pressure reduction once other neurologic emergencies, notably ischemic or hemorrhagic stroke, are excluded. Appropriate agents for the management of hypertensive encephalopathy include intravenous nicardipine, labetalol, phenoldiprem, and clonidine, although the latter two are not available here. We do not use nitroglycerin because it dilates cerebral arteries and alters both global and regional blood flow, which may worsen the autoregulation failure. The ideal targets for blood pressure control in subarachnoid hemorrhage and ischemic stroke are not clear and should be balanced to avoid worsening ischemia or rebleeding. For subarachnoid hemorrhage, recommended agents include intravenous nicardipine, labetalol, without one superior agent to date. Oral nimodipine is a good choice for those with modest blood pressure elevations because it lowers blood pressure and reduces vasospasm and subsequent cerebral infarction rates, improving neurologic outcomes. If an anticonvulsant is used and an agent that may further reduce blood pressure is selected, such as intravenous phenytoin, which is rate dependent, or a benzodiazepine, caution must be exercised with additional blood pressure reduction attempts. The treatment of hypertension in patients with intracerebral hemorrhage includes labetalol, nicardipine, and esmolol. Enalaprilat may also be used, but due to concerns of precipitous blood pressure drop, start with a smaller test dose of 0.625 milligrams. Lowering systolic blood pressures from 180 millimeters mercury to 120 to 160 may improve clinical outcomes. In ischemic stroke, moderately elevated blood pressure may be beneficial in preserving cerebral perfusion of ischemic areas. Conversely, it may also worsen edema and contribute to hemorrhagic transformation. It is likely that ideal blood pressure ranges exist for ischemic stroke subtypes, but at this time they have not been determined. For the treatment of ischemic stroke, labetalol and nicardipine are the recommended agents, but the route and degree of blood pressure reduction depend on whether the patient is a candidate for reperfusion therapy. Fibrinolytic therapy shouldn't be used in patients who maintain a blood pressure of greater than or equal to 185 over 110 after antihypertensive therapy, but in those who maintain blood pressures of less than or equal to 185 over 110 with or without antihypertensive therapy and undergo fibrinolytic therapy, blood pressure goals are at or below 180 over 105 millimeters mercury. Blood pressure should be monitored every 15 minutes for 2 hours from the start of recombinant tissue plasminogen activator therapy, and then every 30 minutes for 6 hours, and then every hour for 16 hours. Specific antihypertensive agents were already mentioned earlier. Parenteral agents that are used for hypertensive emergencies can include beta blockers, especially labetalol, which is unique among commonly used beta blockers because it also has modest selective alpha-1 inhibitory effects with an alpha to beta blocking ratio of 1:7. It is recommended for nearly all hypertensive emergencies with the exception of cocaine intoxication and systolic dysfunction in association with decompensated heart failure. In the latter, nicardipine is preferred when nitrogen fails. Oral metoprolol is indicated in the majority of patients presenting with acute coronary syndromes. Oral beta blockers have a clear benefit in terms of survival, whereas mortality data are conflicting with intravenous formulations. However, if blood pressure control is needed in the patient with acute coronary syndrome, the intravenous formulation should be used. Esmolol has a short duration of action and is titrable, an advantage in patients at risk for the adverse effects of beta blockers, such as those with severe asthma and chronic obstructive pulmonary disease. Nicardipine has an onset of action of 5 to 15 minutes and can be titrated at 15-minute intervals. It has been found to be safe and effective in neurologic hypertensive emergencies and has a favorable effect on myocardial oxygen balance, increasing both stroke index and coronary blood flow. When compared to labetalol, patients were more likely to reach physician-specified blood pressure goal in the initial 30 minutes of therapy. Nifedipine use of 10 milligrams per RM is discouraged in hypertensive emergencies except in peripartum patients. Nitroglycerin is a potent venodilator, showing arterial dilatation only at very high doses. Use may cause hypotension and reflex tachycardia, both worsened by the volume depletion characteristic of hypertensive emergencies. Nitroglycerin is recommended as a first-line agent only in the treatment of heart failure and acute coronary syndromes due to its favorable effects on coronary blood flow and cardiac workload. Its hypotensive effects are due to its reduction of preload and cardiac output, which makes it a poor choice in other hypertensive emergencies. Sodium nitroprusside is best used when other agents fail. It requires more titration than nicardipine in hypertensive neurosurgical patients and has higher mortality rates in cardiac surgery patients when compared to clevidipine. Concerns about cyanide toxicity heightened in patients with renal or hepatic insufficiency and the need for invasive monitoring further curtail its use. Combination therapy is the most common current use, as in aortic dissection patients who also receive esmolol to achieve blood pressure targets at low doses. Phentolamine is used successfully in cocaine, amphetamine, and pheochromocytoma-related hypertensive emergencies. And allopurinol, which is the only available IV angiotensin-converting enzyme inhibitor, has special applications in patients with heart failure or acute coronary syndrome, but caution should be exercised because of common first-dose hypertension. Clonidine, which is a central alpha-2 agonist, generally does not have a role in treatment of patients with hypertensive emergencies, with the exception of those who have recently stopped taking the drug. An abrupt cessation of clonidine can induce rebound hypertension, which may be difficult to control with other agents. It can be given orally at 0.2 to 0.3 milligrams initially, with blood pressure reduction starting within 30 to 60 minutes and peaking at 2 to 4 hours. In patients who are unable to take oral medications, a clonidine patch for dermal delivery may be used. However, the onset of action may be delayed by 2 to 3 days and titration is challenging. For maximum absorption, apply the patch to the chest or upper arm. Although abrupt cessation of either clonidine or a beta blocker may result in rebound hypertension, clonidine withdrawal tends to be more severe and often will not respond to therapy without institution. When we treat asymptomatic severe hypertension, this does not necessarily prevent or reduce short-term patient morbidity or mortality. However, a small study demonstrated an increased risk of cardiovascular events within 4 years of emergency presentation in hypertensive urgency patients with a systolic blood pressure of greater than 220 millimeters mercury and or diastolic blood pressure of greater than 120 millimeters mercury compared to control patients with systolic blood pressures between 135 and 180 millimeters mercury and diastolic blood pressures between 85 and 110 millimeters mercury. These data, combined with the evidence that uncontrolled blood pressure is a major risk factor for cardiovascular disease, renal failure, and cerebrovascular accidents, are reasons to initiate outpatient blood pressure reduction regimens prior to discharge. Intravenous agents that are used for hypertensive emergencies include labetalol, which is a combined selective alpha-1 adrenergic and non-selective beta-adrenergic receptor blocker with an alpha to beta blocking ratio of 1:7. It takes effect in 2 to 5 minutes, peaking by 15 minutes with a duration of 2 to 4 hours. Renal, cerebral, and coronary blood flow is maintained with minimal placental transfer. However, it is pregnancy category C. We avoid its use in patients with bradycardia, first-degree heart block, uncompensated cardiac failure, or active bronchospasm, and in patients receiving IV verapamil or diltiazem. We use it with caution in patients with liver impairment because effects may be prolonged and the elderly have a less predictable response and more toxicity. Esmolol is ultra short acting, it's cardioselective, and it takes its onset within 60 seconds with a duration of 10 to 20 minutes. It's ideal for use in patients at risk for complications from beta blockers, especially patients with mild to moderately severe left ventricular dysfunction or peripheral vascular disease. We avoid its use in patients with bradycardia, heart block, cardiogenic shock, decompensated cardiac failure, or active bronchospasm, or in patients receiving IV verapamil or diltiazem. We exercise caution in patients with asthma, COPD, uncompensated cardiac failure. Extravasation can lead to skin necrosis and slowing. Anemic patients will have a prolonged half-life because the drug is metabolized by red blood cell esterases. Nicardipian is a second-generation dihydropyridine calcium channel blocker with vascular selectivity for the cerebral and coronary arteries. Onset of action is 5 to 10 minutes with a duration of 1 to 4 hours. We avoid it in patients with advanced aortic stenosis. Caution in decompensated heart failure. We avoid it in patients receiving IV beta blockers. Common side effects are headache, hypotension, vomiting, and tachycardia. Nitroglycerin is a potent venodilator and only at high doses affects arterial tone. Onset begins at 2 minutes, duration is 10 to 20 minutes. Case duration is 3 to 4 hours unless removed. Reduces blood pressure by reducing preload and cardiac output. Decreases coronary vasospasm and cardiac workload. We avoid it in cases of compromised cerebral and renal perfusion. Avoid concurrent use with phosphodiesterase 5 inhibitors such as sildenafil within the past 24 to 48 hours. It may cause hypotension with reflex tachycardia, which is exacerbated by volume depletion. So, not advisable for people with hypovolemic shock. Nitroprusside is an arterial and venous vasodilator due to its interaction with oxyhemoglobin to produce nitric oxide. It decreases preload and afterload. Onset of action is in seconds, duration is 1 to 2 minutes. Cerebral blood flow is decreased, whereas intracranial pressure is increased. We avoid it in patients with kidney or hepatic failure, arteriovenous shunts, hereditary optic nerve atrophy, or elevated intracranial pressure. Intraarterial monitoring is recommended. It must be protected from light. Nitroprusside is recommended only when other agents fail. Coronary steal syndrome may occur. Phentolamine is an alpha-1 and alpha-2 adrenergic blocking agent effective for pheochromocytoma and hypercatecholaminergic-induced hypertension. Myocardial infarction, cerebrovascular spasm, and cerebrovascular occlusion have occurred after its administration. For enalapril or enalaprilat, it's an angiotensin-converting enzyme inhibitor with a test dose of 0.625 milligrams recommended when concern for first-dose hypotension exists. We avoid it absolutely in pregnancy. First-dose hypotension is common, especially in high renin states. It may cause dizziness and headache. So oral agents for hypertensive urgencies include labetalol, captopril, losartan, nifedipine as an extended release tablet indicated for preeclampsia only, and clonidine with a primary indication for rebound hypertension. When we reviewed the JNC recommendations, initial therapy recommendations for most patients is a thiazide diuretic such as hydrochlorothiazide, an angiotensin-converting enzyme inhibitor such as lisinopril, or a calcium channel blocker. However, in Black people, we initiate a thiazide diuretic or a calcium channel blocker alone or in combination. In patients with chronic kidney disease, whether without diabetes, we initiate an angiotensin-converting enzyme inhibitor or an angiotensin receptor blocker. The epidemiology, presentation, and management of hypertensive emergencies in children is less well documented, and there is no formal definition of hypertension crisis for children. It is defined as systolic and or diastolic blood pressure measurement that exceeds the 95th percentile for that child's age, sex, and weight on 3 or more occasions, and it could be made using pediatric nomographs. A single elevated blood pressure in the emergency room is insufficient to diagnose hypertension. Severe blood pressure elevation can be considered any blood pressure that exceeds the 95th to 99th percentile for that child's age, sex, and weight by an additional 20 millimeters mercury or more. So when it comes to patients with increased blood pressure, if their systolic blood pressure is 120 to 160 systolic or 80 to 100 diastolic, we advise follow-up within 2 months. If 160 greater than 100, we advise follow-up within a month. If greater than 180 or greater than 110, we consider initiating therapy at discharge and follow-up within a week. And at 200 or greater than 120, we begin antihypertensive therapy at discharge and follow up within. So, hypertensive emergencies in children are also severely elevated blood pressures, which are accompanied by target organ damage. Neonates may present with apnea, cyanosis, irritability, and poor feeding, but older children may have symptoms that more closely approximate adult presentations, such as headache, confusion, or encephalopathy, focal neurologic deficits, vision changes, shortness of breath, peripheral edema, and decreased renal output. In children who are noted to have severely elevated blood pressures but no evidence of target organ damage, a pediatrician is consulted for outpatient follow-up or initiation of an antihypertensive agent prior to discharge. In patients who are pediatric and present with a hypertensive emergency, immediate blood pressure control is needed along with consultation with the pediatric intensivist or nephrologist with admission to the pediatric intensive care unit. This is because elevated blood pressure in the pediatric population is usually due to renal issues. So the aim of therapy is to reduce the blood pressure to the less than 95th percentile and to less than 90th percentile in the presence of comorbid conditions like diabetes or cardiac or renal disease. The mean arterial blood pressure should be lowered no more than less than or equal to 25% of the initial value in the first hour, with normalization of blood pressure gradually over the next 24 to 48 hours. Preferred first-line medications for hypertensive emergencies in children include labetalol, 0.2 to 1.0 milligrams per kilogram per dose up to 40 milligrams per dose, or an infusion of 0.25 to 3 milligrams per kilograms per hour, or Nicardipine 0.5 to 3 micrograms per kilogram per minute infusion. Second-line agents include hydralazine 0.2 to 0.6 milligram per kilogram administered as a bolus to a maximum of 20 milligrams, Esmolol administered as a 100 to 500 microgram per kilogram loading dose followed by an infusion of 50 to 150 micrograms per kilogram per minute to a maximum of 1,000 micrograms per kilogram per minute. And if prior drugs fail, we use IV nitroprusside 0.5 to 10 micrograms per kilograms per minute. Phentolamine at 0.1 milligram per kilogram to a maximum of 5 milligrams is the drug of choice for conditions associated with high circulating catecholamines such as cocaine or pseudoephedrine overdose. So indications for specific antihypertensive therapy include a blood pressure goal, first-line therapy, and second-line therapy. So for heart failure, we want, or rather actually for all of these diseases, for heart failure, post-myocardial infarction, high coronary artery disease risk, recurrent stroke prevention, diabetes, and chronic kidney disease, we reduce the blood pressure to less than 140 over 90 millimeters mercury. First-line therapy for heart failure is a diuretic with ACE inhibitor, and second line is a beta blocker. For post-myocardial infarction, first-line therapy is a beta blocker or ACE inhibitor, and second-line therapy is an aldosterone antagonist. For high coronary artery disease risk, first-line therapy is a beta blocker, second-line therapy is an ACE inhibitor, calcium channel blocker, or diuretic. For recurrent stroke prevention, we use a diuretic with ACE inhibitor or ARB. For diabetes, for most patients, thiazide diuretic, ACE inhibitor, ARB, or CCB, but for blacks, ACE inhibitors and ARBs are contraindicated. And for chronic kidney disease, we give an ACE inhibitor or ARB because it acts on the renin, angiotensin system, and we like to target that for kidney disease. And generally speaking, second-line therapy is the above alone or in combination with other drug classes. And that's it. Thank you so much.